According to the European guidelines, the options of therapy that we have in order to rescue our patients after transplant are basically based on Lendex-based combination or PI-based combination. But today in 2019 we have to consider that the first line of therapy is going to clearly influence the subsequent lines of therapy, especially after autologous stem cell transplantation, because lenalidomide is the standard of care after autologous stem cell transplantation as continuous therapy. This means that most patients we are going to face at first relapse after transplant will be lenalidomide refractory. In this situation, we can consider that the best option to rescue these patients are PI-based combination, basically carfilzomib and dexamethasone or daratumumab in combination with bortezomib and dexamethasone. And both combinations are effective and can be used at first relapse. However, new combinations are coming, especially to rescue these patients lenalidomide refractory. These combinations are basically based on pomalidomide and dexamethasone. Pomalidomide is the new immunomodulatory agent that can rescue patients previously treated with lenalidomide, and the most consolidated data for this patient population are coming from pomalidomide, bortezomib and dexamethasone. But not only, it's also possible to combine pomalidomide with carfilzomib dexamethasone, pomalidomide dexamethasone plus daratumumab, and maybe also carfilzomib dexamethasone plus daratumumab. So in summary, I think that today after transplant, for lenalidomide naive, Lendex plus something else is the standard of care. Most patients after transplant will be Len refractory. So for this population, today carfilzomib and dexamethasone, daratumumab, bortezomib and dexamethasone. In the near future, pomalidomide dexamethasone plus new agents.